Good morning. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. And we'd like to welcome everyone, all the members and our guests this morning. We have a very special lady with us here today, a great friend. She's been a friend with Trio now for the entire time we've been in existence. In fact, she was one of our first speakers. And that is Dr. Silke Niederhaus from UMMC. Today's meeting is on the topic that we all need to learn more about, which is COVID-19 today, what transplant patients should know. Our next meeting will be October 9th with Dr. Dori Segev from Hopkins, and he will be talking about transplantation and COVID-19. And now I'm going to turn the meeting over to Michelle, and she will introduce our speaker.
Hi, good morning. It's nice to see everybody. It's a big crowd. Today's guest speaker is Dr. Silke Niederhaus, who many of you know. She will talk about COVID-19 today and what transplant patients should know. All the questions we're interested in finding the answers to. Dr. Silke Niederhaus is the Associate Dean for Faculty Affairs and Professional Development at the University of Maryland School of Medicine and a clinical associate professor of surgery. Dr. Silke specializes in kidney and pancreas transplantation, laparoscopic and single port donor nephrectomy, and dialysis access. She has published a number of papers and abstracts, many of them centering on organ transplants, organ donors, and recipients. Dr. Silke is a kidney transplant recipient herself. Her first kidney transplant lasted for over 30 years. She needed a second kidney transplant in 2019, for which she was able to find a living donor through a paired kidney exchange. Her experiences as a transplant recipient allow Dr. Silke to bring a unique perspective to transplantation, which we all benefit from. So please welcome Dr. Silke. And Dr. Silke, we thank you for addressing our Trio group. Welcome.
Thanks, Marty and Michelle, for inviting me. I'm glad I made it. I had a little bit of a busy and crazy week behind. Initially, I'd planned to record a talk for everyone. In case I was stuck in surgery, but then it turned out I'm not stuck in surgery yet and hopefully won't get stuck, but I may have to answer some text and phone calls in between. So apologize in advance, but here we are somewhat together, right? And somewhat not. So I'm going to share my screen. I am talking about COVID-19 in today's day and age, kind of from a transplant patient perspective. And I am a surgeon. I do kidney transplants mostly at the University of Maryland. But what I'm talking about here is sort of what I've learned as a patient, what I know as a doctor, for myself to be true. And I don't represent the University of Maryland themselves, right? I don't represent the School of Medicine. I'm just, here as me. I don't have any disclosures. Nobody's paying me big money to give this talk. But I do have, in terms of disclosures, I guess my experience as a transplant patient plays into some of my opinions and things that I hold. So we should, be sure to recognize that. I think today we're going to talk a little bit about how severely COVID-19 can affect transplant patients. We're going to talk a little bit about the COVID-19 vaccines. I know that's a very controversial topic, how well they work in transplant patients, especially what we should know about that, what kind of could be relevant for us, our friends. And then, how the Delta variant really is different than from what COVID has been before then. I've started actually by doing, and I was going to put a picture of the solar eclipse, which now clearly I realize I forgot to do that, of COVID-19. It's really a coronavirus, right? And there's many, many viruses out there in the world, but the coronavirus corona really means crown. And I know whenever there's a solar eclipse, you see that big crown around it, and that's a corona. So the coronaviruses are a group of viruses that all look a little bit similar in that way. And I'm sure everyone has seen this picture by now of the coronavirus. And you can see sort of on the outside, the crown with the little pointy parts, right, that we've come to know as the spike protein. So this is what the virus looks like, okay? And, this red little thing is the spike protein, and that's what the virus uses to get into our bodies. And we'll talk a little bit more about that. So I made some very simple illustrations and graphics for all of you, and we'll see how it works. But it's a virus, right? There's different kinds of infections that come after, especially transplant patients. Viruses are special. The other ones are bacterial infections or fungal infections. There's also parasitic infections, but mostly transplant patients, because of our immunosuppression, we're prone to viruses more than anything. So what is a virus? The first virus that was discovered, this is interesting for us Marylanders, was really the tobacco mosaic virus that affected the tobacco plant. And that was the first virus they found as an infectious agent, right? And unlike a bacterium or a parasite or a fungus, a virus in and of itself doesn't live, and it cannot live without the help from some other host that it infects, and the cells of which it uses then to make more virus. So that's a unique thing about the virus, is that it needs a host in order to replicate and in order to keep going, okay? So most viruses are made out of either 2 or 3 parts. The red part, and I coded it here for everyone, is a DNA or RNA. It can come as a single or as a double. In coronavirus, it's RNA or ribonucleic acid. This is genetic information. Deoxyribonucleic acid is the DNA, right? So humans are made out of DNA. And coronavirus carries only ribonucleic acid, right? So it's made out of RNA. And you see one single strand of RNA is what the coronavirus is made out of. It's a very simple thing compared to the humans who have multiple chromosomes full of much, much more DNA. Then around it, this DNA or this RNA encodes a couple of proteins. And so the virus makes a little yellow protein coat that's also known as a capsid, in which it hosts and houses its RNA, its genetic information. And then the coronavirus, but not all viruses, on the outside of their coat have a lipid envelope. So some viruses have this lipid envelope and some viruses don't. And this lipid envelope is actually part of the cell of the host. So our cells, that if they get infected with coronavirus, contribute to making that outer layer for the virus down the road, okay? So how do viruses work? Viruses have a little bit of a life cycle, kind of like humans. You know, we're born, we grow up, we get pregnant, we have kids, you know, we raise our kids, and when they get old, we die, and life goes around and around. And viruses are a little bit similar, although for them, these things happen within hours or days, as opposed to us, it takes a lifetime. So the first thing a virus has to do is attach to a cell, okay? And different viruses do that differently. Then there's this process called endocytosis, which means the virus, after attaching to the cell, gets put inside the cell. And I'm going to try to show a video in a minute. Once it's inside the cell, it has to uncoat. So it takes its like outer layers off, right? And it has to let the RNA, the genetic information, out into our cell. Inside the cell, then, the RNA that's floating around is something that our bodies have RNA too. We make RNA out of our DNA. And the body, the cell then uses our machinery. Our cells use the RNA to copy what there is of the RNA, because that's what our cells do all the time, every day. That's how we are alive. But now the cell, instead of making RNA it's supposed to make, is making more and more virus proteins and pieces. After that gets made, then there's instructions for how to assemble it, right? It's kind of like, you know, when you get new furniture and there's instructions, you assemble it and put it together. Our cells do that. They do that expertly day to day. That's how we make protein and albumin and all these other good things that help us live. And then after things are assembled, the cell releases the virus, except one goes in and hundreds of thousands come out. Once they come out, these hundreds of thousands attach to some other cell. And so this whole thing keeps going and becomes worse and worse. And that's how ultimately we get sick with viruses. Okay. So let's see if this works. Maybe it will, and maybe it won't. Maybe it opens in another window. Of course, it's not working. Whoops, hang on, maybe. It's thinking, hang on, I'm going to stop this. And I'm going to switch to sharing another window. I'm going to show you a YouTube video because why not, right? We can all watch YouTube. Let's see if it's optimized for video sharing. Can you see this? Let's see how I make a big full screen. And this is the coronavirus up here, right? And these are the receptors on our cells. And I don't know if you're going to be able to hear anything, but don't worry, I'm going to talk through this. So, all right. Here's what we're going to do. We're going to play this video. And what you see is this virus is floating around in the air. It's coming near our cell, and the cell has receptors. And once it connects to one receptor, the other receptors get invited to come join. They now hold on tightly to this virus. And see how it's sort of like a balloon that goes inside a balloon when you stick your thumb in? It takes it in and then makes a bubble on the inside. Once it's on the inside, there's little things that happen to let the RNA out. And then that RNA floats around freely inside our cell. And that's how the whole thing starts, okay? Let me close that video before it starts talking to me on my background. Else that's gonna be kind of crazy. All right, and hang on. I have to start my share again. Too many buttons to click. We'll get it though. Here we are. And we'll go to the next slide right there. All right, that was not the most smooth way to show a video, but here we are, okay? So now you saw a little bit, you have a little bit of an idea of how a virus sneaks in, right? And this coronavirus is kind of funny because it uses something that maybe some of you know. If you have high blood pressure and you've ever been on an ACE inhibitor, those are all these drugs that end in pril, like lisinopril, monopril, captopril, whatever pril, right? Those are the receptors that help our blood pressure go up, okay? And the ACE inhibitor binds to the same receptor to block our blood pressure from going up. So the virus uses this receptor that's prominent in our lungs to get into the cells. And this is how it works. It's kind of funny. So the virus RNA then gets out. You saw that. Our cell reads that RNA, and that's what it normally does, and makes the proteins that are encoded, right? The RNA is like genetic information, and cells take the genes and turn them into proteins. That's kind of like a factory, right? You get parts put in with a manual instruction. You turn it into proteins, and once you have the proteins, they get put together in a certain shape or in a certain thing. Kind of like how cars are made in the car industry, except our cells do it, you know, on a microscopic basis with all sorts of things. So eventually, if you imagine in that video how that virus got inside the cell, once you have it assembled with the RNA inside and with the little protein capsid around, it gets out of the cell the same way. So these little capsids attach to the inside of the cell wall. And then the bubble that forms around it is our own cell wall, except that cell wall on the outside now has proteins of the virus that are that spike protein, because that's how it gets put together before it sneaks out. Isn't that crazy? It's a very sneaky thing. So here I have it sort of, again, imagine this double lipid layer is our cell layer, right? And now we've made all this RNA and all these capsids, we put it all together. And then eventually it sneaks out, and every little thing borrows a little bit of this wall on the outside, okay? So getting into the next, and I saw there's a question up, and how big is a cell? Oh, it's microscopic. Probably the first cell I ever saw is a thing under a microscope, like of a tree. But they're tiny, like, you know, your skin cells, when you have dandruff, sometimes you can see a bigger cell, but cells are very, very small. And our body is made out of many, many, many millions and billions. And I don't even know how many cells we're made out of. Way too many for me to count. So they're tiny. A red blood cell, you can see under a microscope, right? A white blood cell too. So how severe is COVID-19? And I think it's important there to know that, you know, we define severity, right? And so the NIH has a classification for disease severity. And so the mildest form of disease you could get is asymptomatic or pre-symptomatic, meaning you have no symptoms. So it is not very severe at all, but you can still have a positive test, right? And this is part of the reason COVID has been so tricky for all the countries to know if there is any, is because people can have the disease but not have symptoms. A little bit like kidney failure, right? You can have kidney failure but not have symptoms for a very long time. But if you got your creatinine checked, it could be elevated and you might not otherwise know. So very similar, COVID can be that way, except kidney disease doesn't spread from person to person, but this infection can. And so you can have many people with no signs or symptoms of infection walking around and sharing the disease with other people who can then get sick. The next level of disease is mild illness, which means that you have some symptoms, but you're not really short of breath and there's no findings. Your chest x-ray still looks normal. So those are a lot of times people that if you're, just a little bit sick with a cold and the sniffles and a slight fever, you can stick it out at home and you may be doing okay. Moderate illness is then defined as a pneumonia. So lower respiratory disease is usually pneumonia. And then usually your oxygen levels become less than normal. So here, less than 94%. So for that, you probably would need to be admitted to the hospital. You may need some oxygen. You may need some other treatments and whatnot. Okay. All these things are pretty survivable if you stay in those three areas. The trouble is really when you get into severe illness, which is usually where you start needing a little more intense care. So your oxygen levels are low, you're breathing much faster than normal. And this respiratory rate more than 30 times a minute taking breaths usually means that you need a ventilator. Also means that half of your x-ray could be, full of pneumonia, and then you have low oxygen levels measured by a blood draw in your artery. Critical illness is then even worse than severe illness. Severe illness really just means that your lungs are infected and they need help by breathing. Critical illness means that it's now more than just your lungs. It's respiratory failure. You're on a ventilator. You may have septic shock or low blood pressure. Your heart's not pumping right, or multiple organ dysfunction. So kidney failure, liver failure. And it's actually interesting to me that I've seen quite a number of people come for transplant evaluation after they had COVID, and they may have had underlying kidney problems to start with, but then they got a COVID infection and now their kidneys have completely failed. So it can make kidneys break, and it can kill people, as we know, right? 600,000 plus people have died from this infection now in our country. So how severe is COVID-19? And this is specifically in transplant patients, and I didn't write it there out of sheer laziness. So in the beginning, right, this is early April of last year, the first sort of impression of how bad COVID was published by Pereira in American Journal of Transplantation. They looked at the first 3 weeks of real, COVID in New York City when this really broke out there as an epidemic. They had 90 patients that presented after transplant with COVID-19. 68 out of 90 were admitted. So that's more than 2 out of 3 needed a hospital bed to get over it. The median age was about 57 years of age. Most of them were kidney recipients. There's more kidney recipients around than any others. Interestingly, many lung recipients were admitted. That makes sense, right? The virus goes there. Some liver, heart, and other kidney, pancreas, heart, kidney, whatever. The symptoms these people had were mostly a fever, but only 2 out of 3, a little more, had a fever. Some did not. Some just had a cough, and a little less than half had some shortness of breath. How long after transplant? We're going to get there. I don't think we have that, but the distance, the time from transplant was very variable in this study because some were really close out and some were years and years out, right? So and among those patients, they classified them really just into mild, moderate, or severe / critical illness. And when you look sort of, some had mild illness, a good part had moderate illness, and then 27 had some severe disease in their group. When you look, 35, so 1 out of 3 ended up needing intensive care and intubation. 16 died, so that's 18%, and really half of all transplant patients who needed intensive care died. And ultimately, good news is just over half were discharged again. Now, the trouble with me showing you that data today is that, this was early on in the pandemic, right? Testing wasn't easy to get. So there's likely quite a number of patients who may have had very mild disease and weren't even tested and just stayed home. Nobody was vaccinated, right? Early COVID was different. This was probably the Alpha variant, right? That was not as infectious and not as, dangerous as Delta is now. Availability of care may not have been optimal, right? We all know that New York City was really swamped in terms of their hospitals and people running out of beds and running out of doctors and people working overtime. So that may have contributed to some of these outcomes. And there weren't very many known treatments, right? We were sort of guessing whether steroids would be good, whether other drugs would work, and we really just didn't have a lot yet. But some people started getting remdesivir in this study, and we don't know ultimately how many people had COVID, may have stayed home and were healthy. Okay, so this was really pretty disheartening, and I think when that came out, even my own doctors were like, no, you're staying home, you're not coming into work, and you're not doing anything. And I was like, but I'm a doctor, I'm supposed to help the sick people. It was a very, very tough time that way, because emotionally, I went into medicine to be there for people in need and in crisis. And now here's a need and a crisis. And I was sort of like, had my hands tied behind my back. That was not nice, not good. So the real problem with talking about COVID in transplant patients is numbers, because it's even very difficult for anyone to find out how many transplant patients are alive in the United States at any one time, right? We know how many transplants we do every year, but it's very difficult to keep track of how many of them are still alive. And then we don't know how many transplant patients are admitted for COVID-19, because many of them get admitted to smaller hospitals that don't report infections back to a centralized system. There's no centralized system tracking infections after transplant. So again, it's very difficult to know really truly how many patients out of how many patients exactly have had what level and what severity of COVID. How they all do, well, who knows, right? The ones who stayed home, some may or may not have been tested. We really don't know. Even the ones who were admitted, there is no national great database to really follow this. So we're missing the denominator of out of how many total patients, right? So everything that comes, we can say, yeah, out of all the patients that were admitted for COVID to our hospital among the transplant patients, this is how they did. But it sort of ignores a big, large group. All right, I see questions coming in. I like it. We'll answer them later, I think. Okay. So this is sort of, how severe COVID is. And I think ultimately the truth is that for any one patient, the disease is going to be any one thing. If you don't get it, or you get it asymptomatically, well, for you, it's asymptomatic. But for other people, it may or may not be. Okay. I'm going to move in to vaccine. Whoops. And there's currently in the United States 3 vaccines, right? 2 are mRNA vaccines that are available. They're called Pfizer and Moderna. That's sort of how they're known in the media. And then there's one adjuvant vector vaccine, which is J&J or Janssen or Johnson & Johnson. Okay, these are available to us. There's other vaccines available, in other parts of the world, another adjuvant vector vaccine. That AstraZeneca vaccine is available elsewhere, but in the United States, these are the vaccines that are available. And the interesting thing is that these are all new vaccine technologies. So we used to, when we made a vaccine, take the virus and break it into pieces and then inject it into people. And now we have much more fancy technology. How well vaccines work is an interesting question, because I think ultimately, we need to ask the question, what do we really want the vaccine to do, right? Do we want a vaccine to prevent death? And I think that's an important thing, right? We all want to stay alive. We're good at this at Americans. Like, we're going to live forever. We're going to be forever young. And we really just don't want to die. So in terms of preventing death, these vaccines work really well in the general population, right? The initial studies showed that 95 out of 100 people who were vaccinated down the road didn't die of COVID, which is great. But they didn't include people like us in the initial studies. So once all the immunosuppressed people got vaccinated, this efficacy rate dropped to about 91% for the mRNA vaccines. And even, I think in terms of preventing death for Johnson & Johnson, it was still a very high success rate, okay? Now, if your expectation is higher, you want the vaccine to prevent severe illness. You don't even want to go to the ICU. The vaccines are still very good at it, but not as good at it as preventing death. But it's okay, because if I'd have to spend a week or 2 or 3 in the ICU and I come out and I walk out and I'm still doing okay and I'm still around, I can survive it. That's great. Okay. And it turns out that even now, most people who are vaccinated among the general population do not die. Very rarely that someone dies, and do not generally get severe illness to need the ICU. Transplant patients, we're a little different. Okay. So we still need to be more careful than the rest of the world. Some people expect vaccines to prevent any infection at all or to eradicate the disease. And we do have vaccines that have done this pretty well successfully, right? If you think about smallpox and how many people smallpox killed, there's no more smallpox in the world, right? My kid learned about smallpox from a cartoon and goes, Mommy, I want to get vaccinated for smallpox. I'm like, kid, you don't need to. The disease is eradicated. It hasn't had a host to live in because the world was so vaccinated that it died out. And so I think that's a lovely goal. I don't know that we're going to get there with COVID-19 at this point in time. It's pretty well unachievable. And maybe in 10 years, we could achieve such a goal. And then the other measurement for can you figure out how well a vaccine works is just measuring how well the body responds to it. And there are different ways of measuring the body's response to a vaccine. But again, that measurement doesn't guarantee that just because the body made a response, that it really prevents severe illness or prevents death, right? So that's an assumed correlation that we think, well, if we measure antibody, it must prevent disease. But nobody's really proven for COVID how much antibody exactly you need in order to never get an infection, or in order to get only mild infection, or in order to not die. So that's a number. We love antibodies. We love hearing about them and measuring them and knowing, and it makes us feel better if we may have some antibodies. But the truth is, there's no study out there right now telling us exactly if you have so much antibody, yes, we know you're safe. And if you have less than that, you may not be safe. We don't know. So the antibody tests that are out there, okay, they're good. They may make us feel better. But in the end, I don't know that I trust it because I don't know what it means. All right, how well vaccines work. So how many infections or deaths happen after the vaccine in transplant patients? This is specific to transplant patients, right? And there's a couple of studies, and it showed that, among people who were vaccinated, according to the instructions of the vaccine, 151 infections still happened in 18,000 patients. So even as a transplant patient, if you're vaccinated, okay, and this is done in July, so there was probably still not a lot of Delta circulating, right? So remember, this is the old version of the virus. We now have a new version of the virus, but they found 151 infections in 18,000 patients roughly. So less than 1 in 100, okay, get infected or got infected then. With those old variants, if you measured the chance of dying once you were vaccinated, it was 7% as a transplant patient, almost 8. Okay, so 8 out of 100 or 7 out of 100, if we got 100 of us infected, there's a chance that some of us might not make it to the next trio meeting. Okay, so it's still important for us to avoid getting infected. But if we were not vaccinated, our chance of dying would be higher. So it's an encouragement that, we have a slightly better chance of sticking around. Okay. So again, when we measure how well vaccines work, it's incredibly hard in the whole country to track all deaths and all infections because people are admitted to small town hospitals that don't do transplant. They may go home, they may do okay. there's no great system to track that all. We can measure antibodies in the blood, right? We can, and antibodies, are things that our body makes routinely, right? When we get a blood transfusion, some of us make antibodies to other people's blood. Some of us make antibodies to other vaccines, right? We've been vaccinated for hepatitis B and we're sort of know that we're immune because we have antibodies. And there's antibodies to HLA. So if any of you get DSA measurements, right, donor-specific antibody, we've made antibody to other people's tissue types, and those affect us in transplant as well. And when you're waiting on the transplant list, your doctors look at a thing called the CPRA, the calculated panel reactive antibody. So there's lots of antibody floating around in our bodies to get tested, okay? So when we look at antibody data, and antibodies are easy to measure, right? Antibodies give us a better idea because waiting for people to get vaccinated and then seeing if they get sick, well, how long do you wait to see if they get sick with COVID? And then everybody behaves differently, right? Some of us are holed up in our own homes and we don't even go to the grocery store. We order everything online. And others are like out there partying and, going to cookouts with their friends and neighbors. So, it's difficult to sort of figure out how well vaccines work in the real world in terms of preventing infection and death when there's nothing standardized. Antibody data is just, you can get the vaccine so many weeks after you're vaccinated, 2 weeks, 4 weeks, you can get a blood draw and then if there's antibody or not. So they did a study here in liver transplant recipients, and after 1 dose of mRNA vaccine after a liver transplant, 34%, a third of people roughly, were immune. And after 2 shots, about 81% of patients were immune. And that's probably higher in liver recipients because liver patients need a little less immunosuppression than everybody else, right? Many liver patients are just on a little tacrolimus or just on a little myfortic or just on a little sirolimus or whatever olimus or other thing they're on. If you're just on one kind of immunosuppression, you're maybe a little bit better off. They also did a study looking at a larger group, right? This is the Hopkins study. I think Dr. Segev will brag on that a lot more when he comes around, where they looked at a whole lot of patients, and I was one of them, right? After 2 doses of mRNA vaccine, 15%, had some antibodies after 1 shot, okay? And just over half of all transplant patients had antibodies after 2 shots. And these are people out, again, a variety of years from transplant, right? Between 2 to 10 and somewhere along those lines. So it depends, but you can see that, if 95% of healthy people make antibodies, even 81 in liver is a little less, and 54 in all organs is a good bit less. So we know that our immunosuppression keeps us from making antibodies as well as everybody else. And that's why we're more likely to get sick and stay sicker longer with whatever head colds and other things we get. So we are. The next question about vaccine is this idea of boosters, right? And it's interesting because a booster is sort of like an extra dose down the line. And a 3rd dose is sort of, well, some vaccines require 3 doses up front, right? So the hepatitis B series is 3 doses up front. So early on, when people learned that transplant patients don't make so many antibodies, people had the idea that, well, maybe giving an extra shot to the immunosuppressed people will yield to a better response, right? And so some people, independently just walked into the next pharmacy or the next doctor's office or the next football stadium and said, hey, I haven't had a shot yet. I would like one, and pretended it was their first shot when it really was their second. And so they collected 30 patients there, aged between 44 and 62, median about 4 years after their transplant, and they went for a 3rd vaccine dose, right? And it was sort of a total mix and match of whatever you could get. If they had Pfizer that day or Moderna or Johnson & Johnson, you got what you got. So of these 30 people, 24 before they started going for an extra dose had negative antibodies, okay? And 2 weeks later, of these 24 that had no measurable antibodies, 6 ended up with high titers, 2 with low titers, and 16, that's the majority, still had no change in their antibody levels, okay? 6 went in for a third dose. They had a little bit of antibody, and 2 weeks later, they actually got a lot more antibody. And of the people that were here vaccinated with a third dose, 15 had like a J&J vaccine, 9 had this is Moderna, and 6 had the Pfizer vaccine. Okay. So it's interesting. Yes, there's maybe a little bit more of a response after an extra booster. But the other thing that this study didn't really look at is to see how transplant patients, they didn't have a control group, right? They didn't look to see at 30 other patients who were vaccinated at about the same time, at about the same age, the same time after transplant, if several weeks after, without getting a booster, they would have made antibody. So because I know that after my second shot, I had no antibody, and then a few months later, all of a sudden there was antibody, even though I had no other vaccine. So it just took me a long time to make the 10 antibodies that I have. So we can talk a little bit about when we, in medicine, look at research, right? So the weakest research and the weakest proof that something works is a case study, right? A case study is basically one day somebody did this once and this is what happened and how it worked. Okay, that's great if it worked for that one person, but that doesn't guarantee that it'll work in 100 people same way every time. A case series is a little bit stronger, right? That's like, say we took 5 patients or 10 patients or 30 patients, and in those patients, this is what we did and this is what happened, and the results are maybe a little bit similar or like that. The next is a cohort study, where we sort of have 2 groups and then we follow them either forward or we look back. So we can look at patients who were listed for a kidney transplant and patients who were not listed for a kidney transplant and see how many of them live 3 years later. Okay, it's a larger group. It has some kind of comparison in it built in, but there are still things that could be different about those 2 groups inherently. A case control study is a little bit stronger evidence still. This is, for example, saying, let's look at people with liver disease and people with no liver disease. And for every person who has liver disease, we're going to vaccinate a person who doesn't have liver disease. And we're going to compare. There should be the same age. They should be, in the same town. They should be the same other background. And, we'll see how those 2 each do different. The next step up, and this is really what we want, are randomized controlled trials, because a randomized controlled trial is where, one patient gets a placebo and one patient gets a treatment. And we try to have both groups similar, and we try to have people blinded so that nobody knows who got what treatment. And then we try to figure out, are there differences in how they do in the future? And then the last is a meta-analysis. A meta-analysis is a study that really looks back at, have there been multiple trials done? Maybe one in England and one in France and one in, Asia somewhere and one in America. And if they all have the same result, then the data becomes much more strong, because now it applies to people all over the globe that may be otherwise different. So ultimately, a group in Toronto did a randomized controlled trial to look at boosters or third doses in transplant patients, and they used the Moderna vaccine. They looked at, people who got 2 doses at 0 and 1 month, and they looked at people who then got 3 doses at 0, 1, and 3 months. And people at 3 months either got saline or the vaccine. The people didn't know, and the doctors didn't know what people got, right, to begin with. Among all these people, then, they enrolled 120 people, right, 60 in each group. They were a median age of 66, median 3 years out from transplant. And then they looked a month after the last vaccine, how many made antibodies, right? And so when they looked in the vaccine group, 71% after 3 doses made antibody, 60% made antibody at a level that they had determined the threshold for, and 71% make neutralizing antibodies. So this is an interesting small difference, because there's different kinds of antibodies that we can measure to COVID-19. One is just an antibody saying, yep, it would attach to COVID, but there's neutralizing antibody that attaches in such a way to prevent the virus from binding to the cell, right? You can make an antibody that looks cute and kind of holds on to it, but if that antibody doesn't keep it from attaching to your cell, it doesn't help you as much as a neutralizing antibody does, okay? So they actually measured two kinds of antibody, whether there was just any antibody, 60%, and in the placebo group, the people who got saline for their third shot, only 13% were able to neutralize the virus and keep it from getting into cells, but still 25% had antibody overall, okay? So again, even after 3 doses, we're not at 90%, okay? The last thing I want to say about measuring antibody, okay, is that if I learned one thing in all my studies and in my 2 years of doing research in the lab and trying to understand how the immune system attacks kidneys and rejects them, or how we can keep it from doing that, is that the immune system of all things in medicine is one of the most difficult and complicated and intricate things to understand. And I think these days, you know, with talking about antibodies, I think we sometimes think that the only thing our immune system does is make antibodies, and we should measure antibodies. And if we have antibodies, our immune system is working great and we're safe. But that's so not true, right? Our immune system has T cells, our immune system has neutrophils, our immune system has monocytes, our immune system has so many different cells. And even among the T cells, there's different kinds of T cells and different kinds of B cells and different kinds of neutrophils and macrophages and whatnot all. And they all play a role in fighting off infections and illnesses. And so when we read studies about antibodies, that's good. I'm glad we're studying it, and it's very worthwhile to do. But we can't just forget that, you know, you can have no antibody in your blood to something and have T cells that are super trained to fight something off on your behalf. That you may be just as safe having no antibody as you are with antibody. Do I have proof that that's the case? No, right? But do I know that our immune system does a lot more than make antibody? Yes, right? And so for me, it means that I can't just look at antibodies and go, this is all that matters, because it's really not. So whether I have antibody or not, I'm like, well, I don't know what it means. I've had the vaccine. I may have had some side effects even. It must have done something, even though we're not measuring it by looking at antibody, but maybe we're measuring the wrong thing. Who knows? And in a human person, how all these things interact, predicting what the immune system does for any given person in any given state is completely impossible. Anyway, that's my rant and understanding of the immune system. I've learned that I'll never fully understand it, so it's too fancy for me. All right, now the Delta variant, okay? So COVID is a virus, and remember that little strand of red little RNA that I showed you? It's genetic information. And when the virus makes multiple copies of itself, it has to copy this RNA very accurately, okay? And now if you imagine your third grader and you give them a fancy page of text to copy, okay? And you tell them to copy it down 100 times. And you have a very compliant third grader, okay? And they're copying it down. Now, you would expect the third grader to make some errors when copying it down. And every copy out of the 100 copies that this third grader is writing is going to look a little different and be the errors are going to be different places. Same with this virus. Most errors that it makes in copying the RNA are not going to change it much. Sometimes it'll copy it such that it just doesn't work. Oh, that's a dud of a virus. Good for us. Most of the time it's reasonably accurate, but sometimes it makes an error that changes something about the virus to make it better at what a virus wants to do, right? So the Delta variant is a small change in the little red spike protein. So if you imagine one little corner, instead of being red, is now blue, okay? And I was too lazy to animate it, but imagine one little corner of each of the proteins is now blue. And that little blue thing makes it more sticky to the cell, right? It now really wants to hold on much better. And now it's more infectious, right? It can get into a cell more easily. And so that's basically what these variants are. So when you hear about alpha, beta, gamma, delta, epsilon, mu, lambda, whatever, right? They're just errors in copying And all of a sudden, the Delta one is the one that was an advantage to the virus that made it a little stickier. So it sticks to your cells a little easier, gets in a little easier, makes you sick a little easier. Okay. And so when we were living under the Alpha variant, mostly, the vaccines did fantastic. We were all hopeful that we wouldn't need masks anymore. We were all hopeful we could go out and back to normal life and everything. And now along comes Delta. And it's funny because I think it's really pretty ironic, because if any of you have studied math, you know that Delta is like the symbol for change. Delta changed the game, okay, in this virus. So it's an appropriately named variant, ironically, even though they just go down the Greek alphabet. So with Delta, what we've seen is that more people who've been vaccinated are still getting sick. The good news is, okay, most people who've been vaccinated don't get deathly ill, okay, for the most part. Exceptions like transplant patients, immunosuppressed people do happen sometimes. But the other thing that happened with Delta is that with Delta, people who've had the vaccine, when they get sick from it, can still spread the virus to other people. So that's why with Delta, we're recommending back to wearing masks and wearing good masks, okay? And so I brought a whole bunch of different sample masks, okay, to sort of show you. Oh, I thought I had a nicer sample in here. Hang on just a second. I have a sample somewhere. Oh yeah, here it is. All right, perfect. So sample one, okay. This is a mask. It's better than nothing. This is the cloth mask, okay. I sewed it myself. It's 2 layers. It's a purple on one side, yellow on the other, okay. It's kind of cute. It's better than nothing, okay. But remember, this is fabric, and the holes in between the fabric are still there, and little tiny virus can still get through. Less will get through than if I'm just talking, but it's safer than nothing. These two are sort of surgical masks, okay? You see they're well-loved, multiply worn by me, to contribute to the environment and good health. They're usually made out of 3 to 5 layers, and they're much better at preventing infection than the no mask, okay? Then there's these other masks. These are called KN95, okay? And they're even thicker layers. They don't have to be fit tested, but they fit very tightly. They seal all around here, and they're a thicker layer a little bit. So they really keep almost 95% of the virus out very well if you make sure they have a seal around your face. And then some of you may have seen these N95 masks, right? This is like where you actually get fit tested and they spray some bitter tasting substance while you try it on. You have to check that it's not leaking to wear it right every time. So it's a little bit user dependent on how safe it is. But so, the safer of a mask you wear, ultimately how I look at it is the more I can not worry about other things, okay? So I approach my life based on, how risky of an activity I'm going to undertake, how risky I think it is, indoor, outdoor, people I know, are they all vaccinated? Are they not? The vaccinated doesn't bother me so much at the moment, but are they masking? Are they not? Are we close together? Are we indoors? Are we singing? Are we yelling? Are we screaming, right? Or are we just sort of quietly sitting there listening to something, watching something quietly on TV? These are different levels of risk. Am I going to be with these people for 5 minutes, or am I going to be with them for 3 hours? Totally different level of risk. Am I going to be with 5 people or with 100,000 people? 100,000 people, right? Depending on our COVID rates, there might be 20 or 30 people there that have COVID. In a group of 5 people, there may not be anyone. So the chances are a little bit better that we'll be okay. So I constantly sort of assess, right? Is the grocery store full when I'm going in? Am I going to go run in to grab one thing real quick? Okay, I'm going in real quick for one thing. I'll be there for 5 minutes and there's nobody there. I'm fine with my little leaky mask, okay? Am I going to really go grocery shopping and stay in there and it's busy, but I need 10 things because I need them? Well, I'm going to mask up. I might even wear eye protection. So I risk adjust like every minute. I'm going to stop sharing and I'm going to start answering some of the questions from the chat. And I think we can have some fun discussion. My wife is a transplant patient. Her unvaccinated cousin is attending a football game, big football game, right? Like yeah, 70,000 people. Should my wife avoid the person going to the football game for a period of time when they come back? Well, I don't know. I don't know how closely related, or how close they are, right? Certainly, I'm not telling my husband to go to a football game. We really wanted to go, right? I mean, we lived in Wisconsin for a while, so Aaron Rodgers is coming to the Ravens in December, and we're like, should we get tickets and take the kid? He's a Packer fan. He thinks he's a cheesehead all the time. He's not. He doesn't even like cheese. So, but I think, it's a risk for the sister to attend the football game. The question is, how many people at the football game will be wearing a mask? Probably not many. They're outdoors. They're going to think this is okay. What's the chance of catching the virus at the football game? Oh, I don't know. Really, it depends on where, right? Like what the rate of transmission is in that area and what big area people are coming from. And it depends on what your risk tolerance is, right? If your transplant recipient wife is vaccinated, and if the person going to the football game doesn't have symptoms, if the person who went is willing to wear a mask and your wife is wearing a mask when they see each other, I think it's okay, because the chance of getting something is not like they have COVID and they're coming to visit. They've done something. Wear a mask, hang out together outside if you can. Don't necessarily hang out inside, don't necessarily eat dinner together for a few days maybe. But on the other hand, it's a thing of risk tolerance, right? Some people are fine jumping out of airplanes and going skydiving for fun, and other people are like, you're not going to get me on an airplane, it's too scary. So if you're scared of it, avoid, right? If you're not scared of it, then be smart about it. Mask, do outdoor things more so. If the cousin is willing to get tested 5 days after the football game or 4 days after the football game and the test is negative, you can stop wearing masks again. Maybe you should be wearing masks anyway. Nobody knows the right answer. There you go. I hope that answers that question. Feel free to type a new one. How big is the cell? We said small. How long after transplant the research is done? Like I said, it's variable, so the data is not perfect. Now, here's a good one. For asymptomatic but positive COVID patients, if they get the vaccine, does it prevent the spread of COVID? And we were hoping that the answer with Alpha was going to be yes, but the answer with Delta is no. You can be asymptomatic and have COVID. You can be vaccinated, and you can still, as a vaccinated person now, spread COVID again, which is why everyone is so exhausted and frustrated, because, we were done with masks. We were so excited to be done, and now we're not. So it's frustrating. Does the vaccine affect people who got silicone implants? I don't know that any study has been done to show that it would affect people or not. But based on what I know, I think if you have silicone implants in your arm where the vaccine goes, you should avoid that as an injection site. I don't think that your silicone implants are going to be adversely affected from getting a vaccine at all, because the vaccine will be in your arm. It'll go inside, that little mRNA strand. If you get an mRNA vaccine, or the little virus thing will sit in the cells in the muscle in your arm. There, it's going to show itself to your immune system, right? In those cells there where it's injected, it's going to show itself to your immune system. Your immune system is going to go, ooh, I should attack this. I should take some of these pieces and drag it to your lymph nodes under your arm, right? Because that's where they are. It's going to drag it to your lymph nodes. You may get some lymph node swelling under your arm, but that's okay, because that's just your immune system dealing with new information, going, oh, I need to teach my body how to deal with this next time. And some people will get big lymph nodes, and some people's lymph nodes will stay small. We're all different. Like I said, the immune system's too complicated for me to predict which of you is going to do which kind of reaction, right? And then your body will learn. But I don't think that your immune system centers around silicone implants, no matter what part of the body they may be in. All right, being on prednisone or steroids from transplants for over 10 years, does it affect getting or not receiving the COVID-19 virus? Yes, absolutely. I think it affects us in the sense that our immune response is different okay, than other people. So when I think of infections in general, and this is me thinking, okay, and how a doctor thinks about it, I think of two things that play together to lead to different outcomes. If you get a big dose of virus, okay, I don't know, your wife is sick with a snot nose and yelling and screaming in your face for the next 10 minutes, okay? And they have COVID and it's spitting at you and it's getting at you. That's a big dose of virus, right? And that big dose of virus, no matter who you are, is going to probably make you sicker than if you have 3 layers of mask on and there's a patient in the same room who happens to have it and maybe one little virus thing sneaks through the mask, okay? Very different, the number of exposure. So part of what the masks do and the distancing is just you get less virus in your system. It's easier for your body to fight less infection because it has a little more time to adjust and respond before that makes copies and copies and copies of itself. The other thing happens is your immune system. Some people, and this is naturally, right, have a super strong immune response to whatever is infecting them. And when that happens, that you have a super powerful immune response, you can have too much of an immune response, and that immune response can attack someone's lungs. And that's how come even healthy people, sometimes when they get the flu, if the immune response is too powerful, even if there wasn't too much flu, that can make you as sick as the flu could. So when you get an infection, it's either too much virus that your body then can't handle, and that's going to make you sick, or it's too much immune response, and that can make you sick. And ideally, we all want to be there where there's some virus and some immune response, and they figure each other out, and we get a little sick or a little more sick or a lot more sick, but then we sort it out and we get over it, right? But the deaths happen on either too much virus or too much immune response side. So we as transplant patients are more likely to fall on the not near enough immune response, too much virus, we died from too much virus side. We're a lot less likely to die from too much immune response side, which some other healthy people can die from. So being on steroids, yes, affects it. Ironically, when people come in with COVID, getting steroids actually seems to be one of the treatments that keeps you from getting super sick with it. So it may protect us, right, from that over response, but at the same time, we're still at risk for having too little of an immune response to it. And same with the vaccine, right? Our bodies are less likely to make that immune response because of these immunosuppression meds that we're on. And that's true for the flu shot. It's true for every other vaccine that we take. Our immune response is not optimal. That's keeping us alive with our transplants. So here we are. Is there a medical reason and ability to get tested for antibodies? So it's a great question. It's not recommended, right? The CDC, the FDA don't recommend antibody testing because the CDC and the FDA, just like we don't know what to make of the results, right? I mean, I did it as part of a study, same as some of you, I'm sure did. And, you know, in the end, after 2 doses of vaccine, I had like an antibody of 10 micrograms or 10 pieces per milliliter. And I'm like, I have no idea what this means, right? It means that, yes, my body had some sort of response. I knew that I had a response when I had a sore arm, right? If you get a sore arm or fever or chills after a shot, your body's responding, right? It's just now you have a measurable response instead of something that you didn't really measure. And I'm like, does it mean I'm safe and protected? No, I don't think so, right? I still think that I have probably a 7%, 8% chance of dying if I got severe COVID or if I got an infection, right? So it's not really helping me change what I do, right? I'm still driving my husband and my kid crazy by wearing masks, right? I still wear my N95 most places I go. I still wear eye protection every time I'm in the hospital, except when I make a mistake. So that's how it is. So someone asked, are there statistics for kidney donors? I don't think there are. I don't think we need them. I think kidney donors who've been vaccinated fall right in there with the general population. And they probably do fantastically well if they're vaccinated. Someone said, got my 2nd dose of vaccine in March. IgG was measured. It was positive. Yep, arbitrary units. So some have higher immunity. That's fantastic. Do I think it's safe to get a 3rd dose? Yeah, I think so. you know, people measure antibody, right? And even in some of the studies that we saw, some people already had antibody levels before they got a third dose. So I think it is safe. I'll tell you for sure, the people who make the most antibody are people who've had COVID-19 infection. And I have a friend who had caught COVID after her first dose of vaccine. And then I said, you should postpone your second dose for a while because you're going to have a crazy immune response. She's a healthy person, not a transplant patient. And she was like, the pharmacist said I should just go ahead and take it. She took that third dose, that second dose of her vaccine shortly after she had COVID, and she was sick with fevers and chills like you wouldn't believe. She's like, oh my gosh, I can't believe it. I'm like, well, you're going to be about as immune as they come. So her antibody levels are just greater than some number, right, above which they don't even measure it anymore. So it certainly doesn't hurt. You may have some more side effects if you have a higher immune response up front. But I think given the fact that they're considering doing boosters for the general population, it probably doesn't hurt. The question is timing. You know, if you're vaccinated in March, you know, should you get vaccinated now? Should you get vaccinated later? I think given the deltas here, it's probably safer to get an extra dose of vaccine than to, you know, count or hedge your bets that antibodies completely protect you. But that's what I'm thinking. There haven't really been many rejections. I think in all of the studies people have done, there was one patient who caught COVID, and I don't know if they were a vaccinated person or not. And then there was one person who had a rejection episode, but it was unclear whether that was due to some other thing with reducing immunosuppression or not. So it doesn't seem like we have worse side effects or serious events in transplant patients after they get vaccinated. So we'll be all right. Heart transplant statistics. I'm not a heart transplant doctor. I would ask the heart transplant group, but heart transplant recipients, I would guess, are on higher levels of immunosuppression than most people, right? So I think they were included in some of the booster doses as well. Especially the COVID-19 study. And so more immunosuppression, usually I would say just get another dose. You know, that's probably what's recommended. And the IgG after the third shot was over 8. That's fantastic. If you're a heart transplant patient and you have an IgG come up, the antibody, that's great. But on the other hand, what do I know about that means you're completely safe or not? Personally, it may not mean that. Right? It may mean that you have antibody, but your T cells still don't know how to fight it in real life that well when it comes. So be safe. Can I address the misnomer that the third vaccine is a booster versus a booster? Yeah, I know the booster. We made so much fun of the word booster because, you know, that's like the rocket going to the moon. You need a booster, or, you know, you're in a car seat, you're not tall enough, you need a booster. And now we have vaccine as a booster, right? So some vaccines require a multi-dose series, right? Like I said, the hepatitis B vaccine, right? You get one dose, you get another dose, and 6 months later, you get another dose. And that's just part of the initial series to get you immune. And I think that's what that Toronto group in the randomized control trial was doing, is to just say, let's give one dose in the beginning, a dose a month later, and a dose at 3 months. And then we'll see how that plays out if a 3-dose series will reach immunity more so in transplant patients than an actual booster. A booster is usually something you do years later, right? We should get our tetanus booster every 10 years. If you haven't gotten a tetanus shot in 10 years, go get your booster, okay? If you haven't gotten your strep pneumo shot, you probably should get that every 5 years. Go get your booster, right? So a booster is something we do years and years later, or months and months later. And so it's a question of, okay, in the randomized trial, yes, it did say, you know, the 3-dose series. Are we all really doing a 3rd dose series when we're now 8 months out from our first shot, or 6 months out, or 4 months out, or 3 months out from our first shot? Is this really a 3rd dose, or is it a booster? It's tough to really know, right? And who knows if we'll ever figure it out. But my kids are already asking, will COVID have boosters every year like the flu shot? And I'm like, dude, you're 8 years old, stop worrying. Let's see. Somebody didn't make antibodies after 2 doses of, I'm assuming Moderna is Moderna. And the transplant team made them hold CellCept 1 week before and 2 weeks after, and they still haven't tested antibodies after, fingers crossed. So CellCept or Myfortic or mycophenolate or whatever you call it, right, is a medication that apparently slows down how well people make antibodies. And people have shown that Should you stop your Myfortic before you get vaccinated or cut it in half or whatever? Don't do that without talking to your doctor, okay? Because it's probably safer to not have antibodies, but have the vaccine in you and still have a functioning organ than it is for you to lose your organ because you're tinkering with your immunosuppression. And now you may have antibodies and we still don't know if they actually protect you. So I wouldn't recommend that. If your doctor tells you to do it, your doctor knows your individual history, knows your risk of rejection, of what everything else going on. Talk to your own doctor about it, okay? So 60% or 4 out of 10 people do not make antibodies. That's true. In transplant patients, that's true, right? But that doesn't necessarily mean, like I said, that they don't have some other immune response that's still valuable and can still give protection from the worst outcome. So we don't know that because, like I said, it's impossible. I mean, the ideal study would be to take a bunch of transplant patients, vaccinate them, and then stick us all in a room with COVID and stick the other half in a room with no COVID, right? And have 10 of us being breathed on by COVID people and 10 of us not being breathed on by anyone infected. And then see how many of us get sick, how many go to the ICU, or how many die. Seems a bit unethical since it's a risky virus, so nobody's doing the study. So it means really we don't know, right? And we're probably not gonna know. But they're doing studies like that about flu and flu vaccines for some healthy people because they know that the risk of death there is low. So we're hearing through the media the booster should be approved and released by September 20th. What is the difference? The difference is really on sort of the package insert, right? If the package inserts, the instructions say you should get 3 shots as a transplant patient, it's not a booster, it's an initial series. If they say you should get 2 doses and then later on get another dose to, strengthen your immune response again, then it would be a booster. So a booster is not always a 3rd shot. A booster could be a 4th shot, a 5th shot, a 10th shot, right? In hepatitis B, I got the initial series of 3 shots. It did nothing. We repeated an initial series of 3 shots. I still had no antibody. Okay, this is years and years ago in medical school, and people were like, we can't let you do liver transplant in patients with hepatitis B if you're not immune. So then they did double doses of the hepatitis B vaccine 3 times. Okay. So were those initial series or were those boosters? I really don't know. I made some antibody eventually. I'm sure I don't have any more. So in any case, somebody says they can't see the masks. So you couldn't see this one? That's the N95. And that one is the KN95. I don't know why they can't see me. May have to turn your video on. And these are just plain old surgical masks, right? One is yellow and one is green. One has ear loops, one has strings, doesn't matter. And then I had my cute mask. I don't know what I did with it now. Oh yeah, here it is. That's my cute little hand sewn mask. Any mask is better than none, but the N95s and the KN95s are better. Is there risk from having higher antibody level? Not that I know of. Quite interested in surviving. All right, so we are. So, right, and a group of 30 with a 3rd or 4th shot. So this is the question, right? I think I wear a mask too. The question is 3 shots enough? Do we need 4? Do we need 5? Do we need 10? Do we just need a higher dose? And I really frankly wish that in the beginning, when they did the first trials, late last fall, right, in normal healthy people, that they would have included a group of 200 or 500 transplant patients. I think many of us would have been more than happy to volunteer ourselves, right? And I wish they would have done the dose trials because maybe we just needed a double dose of the vaccine, right? Maybe we just needed 2 shots of a higher dose than everybody else. Nobody's ever even looked at that, right? And I mean, who wants to get 5 or 6 shots when you have like side effects for 3 to 5 days after? I mean, I had some real side effects with mine and I'm like, oh, do I want to take another week off of work to get another shot? What does it mean to have more antibodies? I don't know. I really don't know. So my strategy is that, yeah, I've had the 3 shots. That's what's currently recommended officially for transplant patients, right? And I'm going to wear my mask and be careful. And in the end, I have to rely a little bit on my faith to sort of say, other people wear N95s anytime. I don't do it in public. I go to my kid's baseball game in a regular mask. I wore no masks in June when there was almost no COVID around in the county, right? But I'm back this fall. I'm planning to wear masks again outdoors when I'm closer to people. If I'm walking by myself in the woods, I definitely don't wear a mask, because you know what? If I'm in the woods and I pass someone for 2 seconds, it distributes. There's wind. I trust the wind in that setting, right? But at the baseball game, if I'm sitting next to other people, I've gone to see the Orioles this summer, right? But when people sit down next to me, I like take my people and I'm like, let's move 5 rows back until there's nobody around us, right? And then I'm okay again. So thankfully attendance is really low. So you can sit somewhere in the upper deck and there's not a soul around. So I think that's very different from going to a football game with 70,000 people around, right? Which I right now wouldn't do. We were really hoping to get those tickets. We're holding off on buying them. Would a KN94 mask be preferred to a surgical mask? Personally, I think it depends on the situation, right? If I'm outside with a small group of people watching kids play baseball, I'll probably just wear a regular mask. It's better than nothing. When I go indoors, I do a KN95. For kids, interestingly, this is curious if you have kids, right? The kids' masks, they don't have N95s and they don't have KN95s, but I found they have a Korean KF94. That seems to be close to the equivalent. So I bought a bunch for the kid for indoor. So now he goes, I have my indoor mask, mom, and then I have my outdoor mask, mom. And then I'm like, he's all in. He like has the whole risk adjustment down. It's a little wild. What about new variants like Mu? Mu doesn't seem to be as bad as Delta, and people don't think it's going to do as much at the moment, but it remains to be seen. And there could be new variants that could be even worse. I hope not. I hope enough people get vaccinated to keep that from happening. People with mild or moderate illness can still get permanent organ damage. Is this very common in transplant patients? You know, interestingly, I've tried to figure this out, and we don't know enough about transplant patients who had COVID and their long-term symptoms. I haven't really heard of too many people that have had long-term issues after COVID in transplant specifically, but nobody's really looked into it very much so. It's still true for normal, healthy people that even children with very mild symptoms can long-term have heart problems, other problems, blood pressure problems and whatnot. I have a friend who has long COVID, and the perfectly healthy person my age who is basically now wheelchair bound can't stand up because they get lightheaded and dizzy, faint, and fall over, right? So the long-term stuff is something definitely to not ignore. Because that's not something I would want. That would probably annoy me more than being in the ICU for 4 weeks. If I can go to the ICU for 4 weeks and be deathly ill and then have to recover from it, y'all, I'll do that. Like, that's fine. But the long thing, that would wear me down. But we don't know. People can still get long COVID. Yeah, I mean, people who are asymptomatic can get long COVID. So, but on the other hand, we're getting to a point where this virus is so common and we're all so tired of isolating. People around us are tired that I think in the end, we're going to end up with some virus somewhere, and probably it'll be endemic and we'll all be exposed to it at some point. So hopefully we'll just get a small dose. Hopefully our vaccine and our immune system will respond and we'll just get over it and everything will be okay. If I can't guarantee it, I can't promise it. I really don't know. Surgical masks better than cloth. Yeah, what fabrics? It's exactly right. It's always apples and oranges when you compare masks. That's exactly right. So, and the fit of a mask shouldn't be underestimated. I love all the masks that fit like this. Have you guys seen the masks that fit like this? That's a great fitting mask. It's doing nothing. You might as well not wear one, y'all. So I make sure that whenever I have a mask, I hopefully have one that fits well and that has as many layers as possible. And somebody said they're sisters, cousins or sisters, doesn't matter. They just know each other. When should monoclonal antibodies be considered? I think that's a great question, right? I think the role for them has traditionally been when you were exposed. It's also when you've been found to be positive, right? And I think from what I've heard, and I'm no infectious disease expert, that monoclonal antibodies are not as effective against Delta as they were for other things. So Delta is sneakier, it's stickier, and the antibodies may not do as much. Immune system is more than just antibodies. Can you look at antibody response by age? We haven't really done this. And as the mom of a 5-year-old liver recipient, I want to tell you, you're lucky it's a liver. That's less immunosuppression. But on the other hand, teach your kid to wear a good mask. Like I said, I recommend the KF94. You can buy it on Amazon. And that's what I did. Someone wants to go to Thanksgiving supper with 5 adults and a 4-year-old. Recommendations: adults are vaccinated and you kidney transplant. I'm a mom of an 8-year-old, y'all. I hang out around 8-year-olds and 4-year-olds and whatnots all the time. So if you want to attend Thanksgiving supper with that group, I would recommend that the 4-year-old sit at the other end of the table from you. I would recommend that ideally the 4-year-old and maybe you should be wearing a mask as much as possible, right? If the 4-year-old goes to play in a different room, you have a different room to hang out with 1 or 2 of the adults at a time, separate by rooms, and leave the windows open, right? Or whatever you can, right? So go in for dinner, take your mask off, eat dinner. I would enjoy dinner. I eat dinner around my 8-year-old all the time. He goes to school now. Y'all, he eats school with other people. I asked for him to sit outside in that group, right? Because that's a little less risk. He wears his mask faithfully. The other kids sometimes drop their masks below their nose, and the teacher thankfully reminds them to put it back up. But nothing's perfect, right? And I think it depends on, do you love family? Do you value being with them? Do it. It's a one-time thing. The risk of something going wrong, it's not zero, never going to be zero. You could walk into the grocery store and catch it there. I would have Thanksgiving dinner. That's what I would do. Teenage kids want to do sleepovers, should they? Depends on with who. I mean, I think if you have like-minded people in the neighborhood, you trust them, let them have a sleepover. They'll take their mask off in a small group, right? Again, it depends on how much virus is there, how close will they be, and how much are they around the other people anyway. If it's a group of a sleepover of like 20 people, and what else are they going to be doing at the sleepover? I mean, this is mom talking, right? Just kidding. But, I think in a small group with a close friend, it's probably okay. But again, it's all probable, right? Statistically speaking, assume when the percent, if 20 out of 100,000 people have it, the chance that your 4 neighbor kids have it is not that high, right? But it's also not zero. So it's all judgment questions. So is it safer for liver? Oh, yes. Get vaccinated before transplant. If you haven't been transplanted yet, the vaccine before transplant tends to work more like a normal person vaccine than after. And even if you only get 1 dose and then get transplanted, you can still finish it a few months after transplant, right? That's not a problem. So, all right. Yeah, some people don't make antibodies. Sometimes it's the dose of the medicine. Sometimes it's just different people are different, right? Even among healthy people, remember, it was 95% effective, not 100%. So some people just don't make antibodies no matter how healthy they are. Should I get the flu vaccine? Apparently, you can take the flu vaccine with your COVID booster or COVID 3rd dose, either way. Here, we usually have people take the flu vaccine a little later, because if you get your flu shot first thing in September, you may not have as much antibody in February when the flu really hits. So you can pay attention to how much flu there is in the community. The Maryland Department of Health usually monitors that. I usually have my kid monitor it. When he tells me 5 kids are out sick, then I start getting my flu shot. He just tells me how many kids are out sick from class. So that's my flu dose monitor. That's how I did 2 years ago. He's like, Mommy, I think it's time for your flu shot. And I went and got my flu shot. But yeah, look for it. There are special COVID wards. They're all in the same ICU. The transplant patients, once you have COVID, go to the same COVID unit. They made me get boosters of every vaccine before someone got listed for a liver. Well, you have good doctors, because they didn't make me do that for my 2nd transplant. All right. When should we get flu vaccine after booster? Anytime. Can't you inject the virus into a blood sample and see how we react? Yeah. We're doing that, right? We're drawing blood from people in some research studies, both here at Hopkins and many other hospitals, to try to see how people react. But I tell you, your blood reacts differently in a test tube than it does in your whole body, because it travels around, it goes through lymph nodes. These systems aren't set up the same. So it's complicated. Getting transplanted lungs that are not vaccinated when the recipient has 3 doses. It's fantastic. I mean, great question, right? Like, should I get a lung from a donor that's not vaccinated against COVID when I've been vaccinated? I think that's probably okay. because the donors, we test them very carefully for COVID. Most donors have to be tested twice. If they donate a lung, they actually get their deep respiratory system tested for COVID. And only if it's negative do people want to use those lungs. And the antibodies and the immune response is in your system. So if you're vaccinated before your lung transplant, you're even better off than getting a lung transplant and then getting vaccinated. So go. And here's the other good question. Correct that all these masks essentially protect others in case you have COVID. But the N95 protects others and yourself. This is a very, very valid point, right? The N95 is like a super thick filter mask, and I can go in and into a room with TB or into a room with COVID, and this protects me. Does it protect me 100%? No, because it's called an N95. It means it filters out 95% of junk, not 100, okay? So it's not perfect protection. That's why we have other layers of face shields and whatnot around, right? But if I get only 5% of COVID in me, the chance that my immune system can fight it is better than if I get 100% in me. So this protects me and it protects others. These masks, you're right, mostly protect the people around you, okay? If you find a mask with a little filter thing on and you have a friend who's wearing that around you, make them put on another mask over the filter because the filter lets breathe out whatever comes out. Okay, so it may protect them, but not you. So those basically consider those masks to have a hole in them. They're holy masks. Should transplant patients get flu vaccine boosters? $1 million question, right? So ideally for your flu shot, this is what I learned from RID doctors and working with them. If you can get the high dose flu shot, right? The one that people over 65 get the high dose flu shot. If you can't, then you get the adjuvant flu shot. There's an adjuvantated vaccine, okay? An adjuvant vaccine. That's a little bit better response in transplant patients. If you can't get the high dose or the other one, but you can get two doses a month apart, you can do that. Like I can do that because I can get one from my employer and one from my insurance. So I sometimes have done 2 shots. Most of the time I just get one because I think one's better than none. And I really don't like getting shots, frankly, but I do what I can. Is there a possibility of getting COVID from an asymptomatic patient through blood transfusion? No cases have been reported. So the great question, can you get COVID from a blood transfusion? No cases have been reported. I personally think COVID to me seems like a respiratory virus. Coronavirus is usually a respiratory virus, flies through the air, right? That's how we get it. Same with the flu. We've used organs, right? And blood from people who have had flu, maybe not blood, but organs from people who died from flu. If they had good organs, we would transplant them. People are starting to use organs like that from COVID patients. If they die from COVID, their kidneys are working great. Why not transplant those kidneys? We haven't started that here yet, but we're talking about it because if it's a respiratory virus and it spreads through the air and through the lung, and it doesn't spread through the blood, but there's no proof, right? It could happen 1 out of 100 times, and we have only done it 50 times so far in the country, so we wouldn't know yet. But I frankly think the risk of getting a virus through blood that's a respiratory virus is low. Anyway, all right, I think we've made it. It was a bit of a longer session than planned, but you all had fantastic questions. So hope it was helpful and hope you all do well and we'll be able to come back.
Silky, we'd like to thank you very much for your time this morning. I know you ran over a little bit. We really do appreciate you answering all the questions and staying after. I also would like to thank everyone who attended the meeting today, both our members and our guests. Thank you very much for taking your time. I want to remind you to check out our website, www.triomaryland.org. The sessions from our transplant conference and our monthly meetings are all posted on YouTube, and you can find the link for that on the front page of our website. I also like to mention that we're very active on Facebook and Twitter, so check us out some afternoon.
Dr. Silky, you already got people asking, when are you coming back again? So
I don't know, y'all. I'm so busy, but that's okay. We'll have to find something else interesting to talk about. We can't just always only talk about the pandemic, as my kids call it.
That is the truth. Thank you so much. This was really awesome. I think everybody learned a lot, and hopefully everyone has a plan of action and maybe feels a little bit better moving forward. So have a great day, everyone. Enjoy the wonderful weather, and thank you.
All right.
Thank you again, Doc.
Take care.
Bye-bye, everybody.
Bye, everybody.